Gilbert's going first? Oh, you guys switched. You had me all screwed up. All right. Well, whatever.
Great. Thank you, Dave, for that introduction. Welcome to those of you joining us on the phone for the webinar, and those of you here in the DC office, particularly since it's supposed to hit 70 degrees the first time in 2010, which is a welcome change after a winter of considerable snow. I'm Gilbert Gim, a health researcher here at Mathematica, and along with my colleague Henry Iries, we're delighted to share our preliminary findings from the National Evaluation of the DMIE, that is, the Demonstration to Maintain Independence in Employment. The DMIE was authorized by Congress under the 1999 Ticket to Work and Work Incentives Improvement Act, otherwise known as the Ticket Act. And from the 2006 solicitation, the demonstration enrolled about 4,000 participants in 4 states, Minnesota, Texas, Kansas, and Hawaii, which all used random assignment in their study design. The demonstration itself officially ended on September 30th, 2009, but the evaluation efforts are ongoing. This presentation next slide, please. This presentation is the work of many individuals working together as a team, including Henry Iries, Boyd Gilman, Noel Denny Brown, and Sarah Croak. In addition, I'd like to extend our thanks to program staff and evaluators from each of the 4 states who are listed at the end of this presentation. And finally, I'd like to thank CMS, Joe and Claudia, who are here in the DC office with us today. To start off with, next slide, please. The Demonstration to Maintain Independence and Employment, or DMIE, has raised a number of interesting questions. But among the evaluation's goals, one of the overarching objectives is to address a primary question, and that is, can an early intervention program providing medical and employment assistance prevent or delay the loss of work and independence due to a physical or mental health condition before a person becomes disabled? And there are 2 elements here that are really interesting and important about this demonstration. The first is that the program is a combination of medical and employment assistance. And it's this integration of a health component combined with an employment support component that is seen as having an influence on maintaining work and independence. And secondly, unlike many other programs or demonstrations that target services to individuals after they have an SSA certified disability, this study is analyzing a population of individuals before they have a disability, hence the term potentially disabling conditions. We'll talk about that in a minute. A second goal is to build on independent state evaluations that are taking place in Kansas, Texas, Minnesota, and Hawaii. It's very much a collaborative effort working with the states as part of the national evaluation. And third, we seek to synthesize lessons learned from cross-state comparisons. These lessons about program implementation may be useful for states in the future that are considering implementing early intervention programs. Next slide, please. So this presentation briefly touches on 3 main research questions. The first is, who enrolled in the DMIE across the 4 states? And we addressed this issue in an interim report that we produced in 2009, which is currently available on the Disability Center website, www.disabilitypolicyresearch.org. And here we'll just highlight a few differences in baseline characteristics. The next 2 questions will be addressed by my colleague Henry Iries. That is, what were the early impacts of the program on disability applications and employment outcomes? And then what lessons were learned from implementing the program in these states. So before delving into the question of who enrolled in the DMIE, I've included a sneak peek at some previews of early impacts. In graduate school, my dissertation advisor met with me before giving an oral defense, and he said, Gil, it's important to not keep people in suspense till the very end. Students who provide a sneak peek of what their results are early on have a much higher likelihood of passing the defense. And so with that advice in mind, I've brought that here to this presentation. The two broad findings we have, first, we didn't find a significant difference in the percentage employed or average monthly hours worked 1 year after DMI enrollment. And my colleague will talk about the estimated magnitudes shortly. But the second main finding, which is very important, is that we did find a lower percentage of participants applying for disability benefits 12 months after DMI enrollment. Next slide, please. So each of the states were allowed to customize and design their DMI program intervention, but there were some similarities and broad eligibility criteria across the states. And this really helps to define the question of who enrolled in the DMIE. The first standard criterion was that all participants had to be working at the time of enrollment. And that's important because at baseline, in effect, every participant has a job. You'll see some very high percentage of individuals employed after enrollment, and this provides some context for that. So everyone is working. The second criterion is the age range was from 18 to 64 years old. So these are all working adults. Some of the states had a lower maximum ceiling, which was 60 or 62 years of age. One state had a higher minimum, which was 21. But by and large, all 4 states stayed within this range. And then the third standard criterion was all participants were not currently applying for or receiving disability benefits at the time of enrollment. And this is important because it provides a useful benchmark reference point. In effect, there are 0 disability applications at the time of enrollment. It does not preclude historical applications, but certainly at the time of recruitment, we're starting at 0. Next slide, please. So in addition to the similarity in these criteria, we found that there were some similarities across the program components across the 4 states. The first of which are the enhanced medical services that we observed. One important point to note here is that the DMIE is actually not an insurance program. The DMIE sought to provide wraparound services to supplement existing health insurance. So all the participants in these 4 states had some form of private or public insurance, and that's important to note here. Some of the examples of wraparound coverage included things like enhanced dental benefits, vision care, home visits in some cases, and medical transportation that went beyond existing Medicaid coverage in some states. In Texas, for example, expedited mental health visits in an outpatient setting was an example of the type of enhanced medical service provided. The second broad component was employment supports. And examples of this include a peer support program in the state of Minnesota and case management leading to access to vocational rehabilitation services in the states. Next slide, please. A third overarching theme across the 4 states was intensive person-centered case management. Each of the states acknowledged this as a key component. In Minnesota, for example, this is called a wellness navigator. In Hawaii, the term life coach is used. And all participants conduct an initial assessment, that is a one-on-one personal interview with each of the case managers or navigators to set employment goals, but also to help the participant get connected to various resources. You can think of the navigator as a system-wide navigator looking at which health services and which employment supports best meet the needs of the participant at that time. And then finally, there are subsidies that were offered to participants in each of the states. There was often coverage of deductibles and lower co-payments, which were substantial, particularly in Kansas, and then premium subsidies offered to participants. Next slide, please. So despite these similarities across the states, we did see some key differences in the target populations by the states. The term potentially disabling conditions was something that states could define within the context of the DMIE program. And I've highlighted here just very quickly some of these differences. In Minnesota, the target population included working adults with severe mental illness and other mental health conditions who were drawn from two public insurance programs, Minnesota Care and General Assistance Medical Care. These are not Medicaid programs. The state of Texas had as its target population working adults with severe mental illness. So again, you see some overlap with Minnesota, but also a second target group that included persons with a behavioral health condition, such as anxiety or depression, co-occurring with a physical condition, such as diabetes or asthma. And they were participating in the Harris County Hospital District, a safety net provider in the greater Houston area for persons that are uninsured. Next slide, please. Kansas included working adults with a wide mix of physical and mental health conditions in the statewide high-risk insurance pool called KHIA, or the Kansas Health Insurance Association. And the high-risk insurance pool was really designed for persons who were not able to obtain group or individual coverage because of pre-existing conditions. So this is a relatively sick population with multiple conditions and challenges in being able to afford health insurance. And then lastly, Hawaii, which targeted privately insured working adults with diabetes, principally type 2, but there were some type 1 diabetes participants in the city and county of Honolulu. One note here is that despite these differences in target populations, you can see that Kansas and Hawaii we have some individuals that are privately insured. Minnesota and Texas are similar in that they're focused on persons who are publicly insured. And again, Minnesota and Texas have these overlapping conditions in mental health. Next slide, please. So this slide just provides a summary of DMI enrollment totals at baseline. As I mentioned at the outset, there were over 4,000 participants nationwide. And here we've summarized the 4 states in order of decreasing total enrollment. So Minnesota had just under 1,800 participants as of September 30th, 2008, which was the cutoff point for enrollment. Texas was the next largest in enrollment, more than 1,600 participants. And then Kansas had 500 participants in total that had enrolled. Hawaii, which had 190 participants, had the smallest size. I should add that Minnesota, Texas, and Kansas had all reached their target enrollment. Hawaii did not, in large part because they started enrollment in April 2008, and recruitment ended September 2008, so there wasn't sufficient time. Next slide, please. So here I wanted to just highlight, again, illustrating who enrolled in the DMIEs, some of the differences in baseline health characteristics and age at enrollment by state. And what you can see here, among the 4 states, Minnesota, Texas, Kansas, and Hawaii, the mean age at enrollment, we see that Minnesota has a relatively young population, or a younger one, at 38.5 years, compared to the 3 other states, which range from 47 to 51 years of age. There's also variation with regard to mean mental health scores and mean physical health scores. These are SF-12 scores, which are composites. They're norm-based with 50 representing roughly the national average. 10 points represents 1 standard deviation. And lower scores here indicate worse health. They range typically from 20 to 80. And what you can see here, Minnesota's mental health score, 35.1, is lower than the other states. That's not surprising, given that their target population is those with severe mental illness and other mental health conditions. In Texas, if we look at mean physical health scores, they have a lower mean physical health score at 38 relative to the other states, which reflects the 2 subgroups that are part of the enrollment population. Next slide, please. And also, here's a snapshot of baseline employment characteristics and education by state. Again, we show the 4 states. You begin to see some similarities in the population as well here. The percentage with a 4-year college degree, in Minnesota and Texas, these percentages, 19% and 8%, are considerably lower than what we observe in Kansas, where 45% and nearly half the sample in Hawaii. So Minnesota and Texas, given the, again, target population, including those in public insurance programs, the educational attainment we see is different than in the 2 other states. This is also reflected in mean earnings as of 2008. At Minnesota, we see $17,000, $15,000 in annual earnings compared to Kansas and Hawaii, which are much higher. And the percentage working full-time based on hours worked in the last month, again, we see roughly a third working full-time in Minnesota and Texas, but a much higher proportion, nearly half, in Kansas and Hawaii. So next, my colleague Henry Iries will talk about the evaluation design and some of our preliminary results.
Well, thanks, Gil. That was a great setup, even if you did steal that punchline with that sneaky peek. So I'll just go on. I'm going to begin with a description of our evaluation design and our approach to the data analysis. Now, I know that some of our federal and state program colleagues here and on the phone may silently groan about some of these technical details, but it is important to know something about what we did and why we did it, because the choices we made with respect to our methods really does influence the credibility of our findings. So I want to make 3 points. First, as Gil noted, our evaluation is based on a randomized design in all 4 states. Now, this means that each state first contacted its target population, and for those who were willing to participate in the project, randomly assigned them to either a control group, which is sometimes called the business-as-usual group, and the treatment group, who were offered the expanded set of DMIE services. So the randomized design is considered the strongest evaluation design possible because it means that the 2 groups are likely to be similar at the beginning of the project, of the study, and any differences we find later on between the 2 groups can be attributed to the effects of the program. So this is really a strong evaluation design. The second point involves what we refer to as an intent to treat analysis. Now, in the real world, we know that some people will sign up for a health-related program and then end up not actually participating, although I'm sure that's not the case with any of us in this room. But, you know, some people use only some, or perhaps they even quit the program before services even begin. They decide it's not for them, or they don't really see that it's meeting their needs. So typically, only some of the individuals who are offered a program actually engage with all the service components of that program. And so in our evaluation, we wanted to mimic that real-world phenomenon by including everyone who was assigned to the treatment group, regardless of how much they participated. Hence, we wanted to analyze those who we intended to treat. That's why we call it an intent to treat analysis. The third point has to do with estimating our outcomes. Now, despite randomization, the control and treatment groups can be different on key variables at the beginning of the project. We want to make sure that if we find differences between the groups at follow-up, we don't mistakenly attribute these differences to the effect of the intervention when they might, in fact, result from differences that the two groups had at baseline. So what we could do is we conduct what we refer to as regression-adjusted estimates, which take into account the variables that I've noted here down at the bottom of this slide. And this adjustment essentially removes the potential effect of baseline differences between the groups, so that if we later find significant differences between the treatment and control groups, we can conclude that it was the result of the program and not the differences at the beginning of the project. So let's move on to the data source slide. And this is where this slide shows where we obtained the data for our analyses. Our quantitative data came from the files listed in the first three bullets. The survey and administrative data that the states kindly sent to us, they were gathering this data as part of their own independent evaluations, and they sent the similar data across all states to us. The SSA file on disability applications, and the ticket research file that Mathematica manages, which includes information on beneficiaries in SSA programs, disability programs, and also the master earnings file, which provides information on earnings. Now, the data lags in these last two files mean that we currently have data through 2008, which gave us an ability to look at information up to 2008 on disability participation and earnings, but not for 2009 yet, which we will have eventually later this year, so we can use that in our subsequent analyses. Finally, to identify lessons learned about program implementation, our qualitative information, we drew on our notes from several site visits to the states, from multiple conference calls, and from periodic descriptive reports that the states kindly sent to us, quite often actually. So let's move on to results. What we are presenting today are highlights of our analysis. There is a lot more detail in our various reports that are already published on the baseline characteristics of participants in the programs, and in the reports that we're currently preparing for CMS that will be available later this spring and in the fall, and then for our subsequent report about a year from now. So I'm going to highlight results related to the impact of the program on percent of participants employed, on the monthly hours they worked, and on the percent of participants applying for SSA disability benefits. And I'll also highlight some of the lessons learned about program implementation. Okay, next slide, please. One of the challenges of presenting a national picture of a program that is being implemented very differently in different states is figuring out how to combine information about kind of apples and oranges in ways that make sense. So what we have done for this presentation is to combine data from Texas and Minnesota. As you may remember from Gil's earlier slides, these two programs had the largest enrollment. Each of them had over 1,500 individuals. And these participants had similar and overlapping characteristics. Many had diagnoses of serious mental illness. About 1/3 were working full-time. And their annual earnings in 2008 were both below $20,000. So overall, participants in Minnesota and Texas appear to be roughly similar with respect to some of their social and economic vulnerabilities. Hence, that's why we combined it in these two states. So this slide indicates that 12 months after enrolling in the DMIE, over 94% of both treatment and control groups were working in some capacity. remember, to enroll in the DMIE, they had to be working, so it's not surprising that most individuals in these states were still working 1 year later, given that they may not have had any other income. And they were working a fair bit, more than really 75% of the time. That is a little less than 120 hours in the month before they were interviewed at the 12-month mark. And it's also important to note that you can still be working when you apply for disability benefits. So some of these individuals may have been in the process of applying for benefits while they were still employed. So next slide. Well, this is what I was just talking about, the average hours worked. I've gotten ahead of myself, so can we go on to the next slide? This is where the story gets a little bit more interesting. This slide shows the percentage of the treatment and control groups who had applied for disability benefits within the 12 months after enrolling in the DMIE. So, and I'd like to make two comments about this slide. First, a relatively small percentage of both groups, less than 7%, have actually applied for disability benefits within the 12 months following the DMIE enrollment. Second, the point here is that a smaller percentage of treatment group participants had applied compared with the control group, so 4.6% versus 6.3%. And this difference is significant with a p-value of 0.05. In these two states, when the data are combined, the DMIE program significantly reduced the number of participants who were seeking SSA disability benefits, as indicated by their applications. So let's go down one more level, if we could, to the next slide, to look at look at information from individual states. The trend is here, again, pretty clear. 7.6% of the control group in Texas applied versus 5.7%. 7.6% of the control group versus 5.7% of the treatment group. And the numbers for Minnesota are 5.1% and 3.5%. Now, I've also included information from Kansas on this slide. In Kansas, less than 1% of the participants applied for SSA within the year following their DMIE enrollment. And this really reflects the different level of economic vulnerability and the diagnostic composition of that group. They had higher assets, and they may not have been quite so, having had quite so much significant impairment. And Hawaii is not included here because in its DMIE program, no one had applied for SSA benefits, again, reflecting that group's relatively higher income and also perhaps less functional impairment. Now, there are a lot of other statistics that we could show regarding outcomes in the individual states and kind of in different combinations. But in the interest of time, I want to highlight some of the lessons learned regarding program implementation, because that's also a pretty interesting story. So the next slide, please. First, the evaluation indicates pretty clearly that the DMIE is a robust concept. It can be implemented in diverse settings with different kinds of populations. Essentially, the participating states showed that they can take this concept of early intervention and adapt it to local resources and local opportunities. The diversity of approaches actually also strengthens the evaluation because it helps shed light on potentially different effects of the program on different populations. And sometimes it's in the context of demonstration programs, that especially ones that other states may be interested in using, knowing what doesn't work well is just as important, or can be just as important, as knowing what does. A second lesson involves strategies for identifying populations of people, of working adults with potentially disabling conditions. There's no ready list of such people out there in the states. So how do you find them? The experiences of the states suggest that building an early intervention program around an existing program, like a state or county safety net program, is one good place to start. You've kind of got a list of people. Building off such that you can then figure out whether they have potentially disabling conditions. Building off such a program also means that you have an existing service network onto which can be added the additional DMIE benefits and employment supports. So a third implementation lesson, if you could go on to the next slide, involves the value of intensive person-centered case management, which Gil explained a little bit, described a little bit. Each program included this service, referring to it in a little bit different way. But in all of the states, the staff from the state programs and a lot of testimonials from participants underscored the value of these professionals, these individuals who are offering this service, in helping participants obtain both the health services they needed and the employment supports. And finally, at least the final kind of implementation lesson I want to mention today is that we realize that early intervention programs may have to be tailored to the right individuals at certain points in the disability trajectory. Now, some individuals with a potentially disabling condition may be able to work with no or minimal assistance. No added services are needed. For them, an early intervention program just isn't relevant. On the other end of the spectrum, there are some individuals who are working with a disabling condition that has progressed so far, has deteriorated so much that they are in imminent danger of not being able to work at all, and may indeed have to have no other choice but to apply for disability benefits, both for income and for access to health insurance. For this group, an early intervention program may just be too late. What the DMIE evaluation and efforts have done is begun to clarify in operational terms where on this disability trajectory it might be most effective to focus programmatic efforts. Okay, let me summarize as we go on to the next slide. So far, our results suggest that at the 12-month mark, the DMIE interventions can reduce disability applications for some target populations, but have little effect on employment. We will await the findings from analyses to be conducted later this year to see if the programs had effects on employment over a longer period of time, whether they had effects on earnings, and also on whether they actually had an effect on enrollment into disability programs. And as I mentioned, the evaluation also indicates that the DMIE concept is robust. As an early intervention program, it can be implemented in very flexible ways. And third, the implementation efforts on the part of the states provide a foundation for beginning to define what we might call best practices in early intervention. There's a lot of the craft of how you implement these programs that have been learned by the states, and which we're trying to capture in some of our case studies. We hope that should additional states have the opportunity to develop other early intervention programs, they'll really look to look for guidance in that effort to the experiences of these pioneering states. And finally, a few final thoughts. Next slide. In a recent publication, Bob Weathers and Dave Wittenberg, whom many of you know, estimate that 15% of working age adults who have work-related limitations are employed full-time. Now, this translates into 1 million people, more than 1 million people, maybe 2 million, depending on exactly how you define disability. And many more working age adults with disabling conditions are working part-time. So the potential pool of individuals who might benefit from an early intervention program may be really quite large. Also, many of these individuals already have health insurance, as the folks who did in the DMIE states. And yet they still do not have access to the services they need to help them keep working, to help their conditions not deteriorate. So providing those kinds of services not only meets the test of common sense, let's go ahead and try and keep them working, but ultimately may save the federal government from having to provide many years of disability payments. A question still to answer in future research. Now, by establishing the DMIE as a demonstration program, Congress clearly signaled its interest in learning whether an early intervention program of enhanced medical care and employment assistance was feasible, and effective. And in fact, a White House press release issued on the day that President Clinton signed the bill in 1999 specifically noted the following: the DMIE evaluation should provide new information on the effect of early health care intervention in keeping people with disabilities from becoming too disabled to work. They realized even way back when this began that evidence is really important. And the report that we are preparing for CMS to submit to Congress later this year and our final report to CMS next year will deliver on President Clinton's promise and provide Congress with evidence that may in fact matter a great deal in shaping the future of federally supported early intervention efforts. Now, a final note, none of this work that we have done so far and that the states have done could have been done without substantial leadership from CMS and also from the state program and evaluation teams. In its role as national evaluator, Mathematica has kind of had an easy job, but we've definitely had the privilege to witness the hard work and the creative ideas and the steady determination on the part of the states to develop and implement this program. This is not an easy thing to pull off in the real world of state healthcare programs, and to gather and share the information we needed to figure out what was working and what was not on a national basis. CMS's early insistence on a strong evaluation design, its commitment to tracking the program closely, and its continued cheerleading have all been very important to this project. And the evidence we've presented today is really just part of a work in progress. And with our partners, who are listed on the next slide, and with our partners, and I think even on the slide after that, we look forward to developing future presentations and publications that will continue to tell this important story of the DMIE. Pat, are you going to follow up?
Well, first of all, thank Mathematica for their great work and for inviting me here, and thanks to CMS for working so hard on this particular project, and thank all of you who are either watching or listening for your interest in this. It is indeed a very important step in the understanding of how to make better policy for persons with disabilities. I appreciate the opportunity to be here. My team that has been working with me on a form of early intervention is also here, and I hope those of you who are here will get a chance to meet them after the meeting is over. The General Accountability Office, and I'm sure most people know what the General Accountability Office does, but I think we always feel obligated to say that who we are and what we do. Now, I understand I'm able to do this, right? No? Down. Am I doing it? Let me go back to the other one now. We are the evaluation and investigative arm of Congress, and our work is to help improve the performance and accountability of the federal government. We evaluate federal programs and policies and provide analysis, recommendations, and other assistance to help Congress make informed oversight, policy, and funding decisions. Wait, I get it. We previously reported, my remarks today are going to be some of them in relationship to what GAO had said in general ways before, but much of my comments are going to be from experiences and what other people have said about disability and early intervention and some of the things we need to think about as we consider both this project and moving forward with the information that we have gotten from this project. We have previously reported that demonstration projects examining the impact of social programs that aim to provide evidence of the feasibility or effectiveness of a new approach or practice are inherently complex and difficult to conduct. And I think that I see Joe shaking his head there that yes, that's true, and I think that we see that, that there's been work on dealing with that in this particular project. Measuring outcomes, ensuring consistency, and quality of data collected at various locations, and establishing a causal connection between outcomes and program activities, and separating out the influence of extraneous factors can raise formidable technical and logistical problems. It's sort of just what Henry said, and it's good to hear that the process that has been worked through to acknowledge those issues, and also that the to hear the evaluation, the evidence, evidentiary and sound research practices that have been applied to the evaluation. We know what the project is and what it's about. I think it's important to say, in my mind, the fact that the persons in the demonstration process were workers with potentially disabling conditions. And I want to spend, well, let me say a few words about just my overall viewpoints of what we've heard. The demonstration itself is an example of the inherent difficulties as discussed in prior GAO reports. And while the generic principle is the same in all of these, there were in effect 4 different populations and interventions. And yes, there has been an effort to group them together for findings from the totals. Evidence in all the populations that persons with chronic health conditions do work and want to continue to work. I mean, that is clear. But even controlling for the differences, it's really difficult at this point to say precisely what was learned and what can be the basis of policy decisions. We know that these were wraparound services, but we know that they were additional services evidently that people could get. And that again is information that's evidence-based that's important to have. This is not, I think we have to realize this is not the complete evaluation, and it mainly tells us now what happened under the 4 different scenarios, but that the evaluation will continue. But it does provide additional clues, and I say evidentiary clues, to early intervention that can increase participation of persons with disabilities. I wanted to go back a bit and talk a bit more about the population, the potentially disabling conditions, and sort of what that means. I know we talked a bit about it from a trajectory point of view, but I think it's important to go back to all the work that's been done on this in the past. IOM in 1991 started a series of reports funded by various government agencies, Institute of Medicine for the National Academy of Sciences, and it was Disability in America. It has had different titles of the various reports that have come out, but the latest one is The Future of Disability in America, and it was published in 2007, I believe. The first one was in 1991, if my figures are right. But it's important to hear this. Disability is the expression of a physical or mental limitation in a social context, the gap between a person's capabilities and the demands of the environment. It is the interaction of their physical or mental limitations with social and environmental factors that determine whether they have a disability. Now, that is generally the current thinking. It's not the medical condition itself that requires the intervention. It's the person, and I heard that said several times. These were personal treatments, and the heterogeneity of the group was recognized. And so I think it's important to come back to this. One of the major conceptual frameworks, and I'm sure many of us in the audience, whether we're home or here, know Saad Nagy's work and the idea of the trajectory of disability. And what this is a frame of reference. And we do rely a lot on there being a health condition. We all talk about there is a health condition, and the boxes represent the progression of that health condition to a disability. And what is really meant here that with these four squares, the definitions that are generally given is that the pathology is the interruption of normal body processes. And then the impairment, the next one is the impairment, which is a loss at the structural or the person level. And then that goes on to produce limitations in functions that get in the way of people performing certain social roles. And one of those key social roles, of course, is work. And that's what we talk about when we attempt to talk about, well, how do we intervene if we're considering the medical process? Now, this is just the first chart. The next chart is one that was developed back when I was in the private sector, and some of my private sector folks are here today in the audience, and that's great. And it attempts to put into this, on the left-hand side, the vertical chart is the employee's ability, work ability. And then the horizontal chart in the middle is the job requirements of a particular job that the person has. And then you see on the top, the line is the progression that Sadnagi describes from pathology to impairment to functional loss. And you can see now this description shows that the person is going along working there is sort of a immediate action, like an acute event, and their abilities drop down below to the function of work. But you could change this whole conceptual piece by interacting, and I think the research shows this, by interacting with the demands of work. You could change the demands of work and therefore change where a person, how a person's functional capacities interact with the demands of work. I think it's a good kind of idea to have when we begin thinking about this, and we're going to add some more to it in a minute. But work disability programs, as we know it in the private and the public sector, they're designed to pay people benefits generally when that point is made that the person cannot do work. It could be any work, it could be their own occupation, it could be Social Security's definition or whatever, but that's when benefits kick in. Few of our programs in the United States consider increasing work capacity or keeping a person at work in any kind of a real formal way before that whatever definition is met that they can't do or they can't meet that definition. Now, we do know that in Australia and some of the European countries that their work disability programs are set up in a different way. You know, a person comes in, they say they're not able to work, and the process then puts them into a work mode that gets them to a job if they can. This is not to take away at all from the need for a Social Security disability program. I want to be clear that that isn't it at all. That this introduces conceptually a period of time where we can have different kinds of interventions that do have payoffs that can help in our federal programs reduce the cost of our federal programs, not to take the place of, reduce the cost. Medical and technological advances, the shift towards service and knowledge-based jobs and changing societal views that I've kind of talked about disability should be increasing the opportunity for more people with disabilities to work and support themselves, current economic conditions aside. Current data indicates this isn't happening to any large number. Henry did reflect on that number that some of the researchers have told us. So a challenge is to examine existing disability policy and programs in light of new and promising concepts and practices that have potential to increase work participation, such as this early intervention, the case management, that sort of thing. Now, this is the more complicated slide that comes from the IOM, and you can't see it, but it does introduce into it, and I'll try to talk you through it. It has that same four boxes of how the medical condition produces a disability, but it also shows that there are all kinds of influencing factors, environmental, biological, and just human performance, our lifestyle and so forth. and that it's not just a one-way street, that disabling process. It's a two-way street, and by considering those other pieces and interacting with those other pieces, you can turn around that progression to disability to turn it back to ability. And I think that's what we're talking about here, and I think that we're seeing from DMIE some good information of how we might go about this. So any objective findings that inform policy issues of increasing work participation of persons at risk for work disability, and that sort of model that I described to you, is very important. And we do have some from these studies, and we can expect more, I think. Sometimes findings come in the form of better framed questions, not just total, so what are the findings, but what are the additional questions that this raises and that we need to ask. I think we have this from these studies. Early intervention may reduce SSDI applications, and that's a good thing. I think that's very encouraging. But the jury's still out on the impact on employment outcomes per se, and I think a lot of that has to do with who the populations were, and we don't really know enough about what their employment situations were, and enough about the employers themselves and why they were continuing to work. So employers play a very great role in all this. I think another great thing is the states. Henry mentioned this about the states, that the states are a great place. We know that disability occurs in the community. I mean, a person is in their community. We know the individualized, and I didn't speak to that enough when I did the last chart with the 3 concentric circles, that all of this is individualized. It is the person and what the person needs at any particular time, and I think that this study also indicates the individualized nature, the importance of case management and that sort of thing in relationship to what an individual needs. Okay. I wanted to just tell you briefly, and this is my team, Michelle Gergich and Dan Concepcion and Barbara Steele-Lowney in the back, which you people can't see that are at home. We've been working on a oops. I haven't done that before. See, I was doing so well on getting my slides together, but I forgot I could drop the slide thing. What we've done we also in GAO have been trying to shed more light on what should this early intervention process be. So the project that we're currently engaged in, we actually had a meeting last Tuesday. We had an expert group of around 60 people that we sent out questionnaires that raised issues about what are the good things that are being done, what are the gaps, what are the barriers, and that sort of thing. We synthesized that, sent out a second survey, came up with some more 7 to 8 sort of general areas, and then the group of 17 experts met on Tuesday and took those and combined them into kind of 3 discussion areas. And we hope from being able to work through these, we got some really great participation. David was part of that. And we hope to be able to formulate some of this into what are some of the actions that can be taken, and certainly information from the DME will help that. We'll be reporting on that sometime later in the summer, and we hope that you'll be looking for it. Okay, in closing, I can totally agree. I'm glad I didn't have to do an in closing slide because it was already done for me. I mean, couldn't say it better. The power of a good idea. And of course, from a GAA poll perspective, evidence does matter. We need to have evidence to support these policy alternatives that we may suggest. But the good idea has to be within the framework, I think, of the current thinking of ability and disability and individualized nature and that sort of thing. And leadership does matter. And I know many of you in this room are leaders and thought leaders in this, and I certainly compliment both Joe and Mathematica again and Claudia. Sorry, Claudia, you are the project leader. I know you're the one that carries the big load for that. So I want to, again, thank you all. I did include some what I think are related GAO studies in the field of disability and disability policy that may be interesting to any of you who want to take this further. So I thank you very much for this opportunity.
Yeah, right. All right. Okay, so we're ready for questions. Who wants to be first? Great.
Hi, Ryan Hess with the Employment and Training Reporter. I'm interested if any of the states are continuing the projects on their own now that the demonstration's over.
You know more about Minnesota than I do? Okay.
So the question about whether these projects are continuing, although the demonstration itself, services ended on September 30th, 2009, a number of states are applying this concept and trying to sustain it in the context of another program. One example is in Minnesota, in which the state was able to secure funding under the stimulus plan to transfer the wellness navigator that was mentioned, the case management, into a VR agency setting. So what's interesting here is that a good portion of the DMI population is continuing this case management, the one-on-one interaction, in a different agency. And so it'll be very interesting to see what their findings are moving forward later this year.
And if you want the person to contact in Minnesota, we are happy to give you that person's name.
Yeah, it's Bernie Wixon with SSA. I guess my question is, it's been run here as state programs, yet many of the benefits from early intervention amount to reduction in federal benefits. So it seems like the analysis of whether this works is difficult because the savings to the federal side don't sort of get factored in terms of whether Minnesota or Texas might continue. And so I wondered, have you been thinking about whether, if the program is viewed as a success, whether what would follow would be action at the federal level in terms of an early intervention program, and what might that look like?
Well, that's a big question. But let me say a couple of things just about the cost issues, because you raised very reasonably the question of how we factored in the cost issues, because this demonstration is largely being funded by federal dollars, but state dollars are in it as well. But you're right, any savings are going to be savings derived from not spending money through SSA disability payments. We haven't done, and we are not really able to do, given our resources, to do much more of a sophisticated cost analysis than what I just said. We're not collecting, that kind of level of data. It'd be really interesting to do so. Whether or not the federal government wants to take some of this information, what we've learned from this and other studies, to develop a broader federal program, I think that remains to be seen for the future.
This did come up in some of our discussions on Tuesday, and I didn't say that the experts, that we chose the experts from a wide variety of stakeholders in this arena, employers and advocates and the federal agencies. And certainly this is something that we believe in GAO needs to be explored more fully, and hopefully that this project that we're engaged in will at least help frame questions better about how to move forward on something like this. And I think the whole funding issue is very interesting because state programs are federally funded in some ways too, and we have the grant system and all those kinds of things. And I don't think any of us are there yet in trying to, I don't think we know what it is we ought to be doing yet, let alone how it is, that we should rearrange the funding. We don't know what it is we ought to be doing per se. We don't know how much it's going to cost. We don't know what the cost benefits are. And I think our really big challenges are trying to figure some of that out.
I respond to, when I was listening, I mean, I guess I've been associated with the Ticket to Work program enough that, you know, one of the things I thought about was, well, if you're able to identify a population that you think would be able to come on the federal disability rolls, then what if, for example, you said to the Ticket to Work program, which provides a lot of these services and support, okay, now you can serve this population, people with severe mental impairments. You don't have to wait until they, in essence, try to get on the rolls and are allowed. Susan Daniels, has probably occurred to you as well.
I wanted to make one comment on this. I think one thing that I was struck by during the presentation, and Henry made a comment about, you know, the states figured out how to attach it to existing programs, but I think in all the cases, everybody was insured, either on a public or private program, and weren't people, potential volunteers, identified primarily through the insurance programs themselves?
Yes, in three of the states.
Not
in Hawaii.
Okay, but it just struck me that, you know, and part of the problem with is a big part of the challenge is identifying the people at the right time, and a lot of people don't have insurance now. But if we're moving towards a world where, you know, insurance is almost universal, which could happen, then, you know, it strikes me that doing this through the insurance system, or having some program that identifies people through the insurance system, offers them something while they're still working, is one approach that could be taken on a federal program.
I want to build on Bernie's question. I'm Michelle Gergich, GAO, being a bean counter. I'm wondering if you can maybe just talk a little more about the barriers to getting at the cost-effectiveness piece, because I'm pretty sure that's hard given that they were leveraging existing problems. So maybe, or programs, maybe you can talk a little bit about the difficulties in doing that cost analysis.
I think yeah, that's an excellent question you raise. Well, conceptually, the investment in these wraparound services is one element. It's possible to sort of aggregate what those costs are. It's challenging in a lot of ways because it is building on an existing program. So there is a kind of a methodological challenge to sort of attributing specific costs to the DMIE versus benefits that are already provided through the existing health insurance that participants have. With regard to a potential reduction in disability applications, I think another challenge here is that while the applications certainly contribute to is one aspect of cost, it's really a disability enrollment and the receipt of payments that matters. So we're looking at this first stage of applying for disability benefits. A fraction of these participants actually have a certified SSA disability, but the large majority result in a denial. Now, of course, those participants can reapply in the future, but being able to assess what fraction of those who apply actually receive disability benefits and then aggregating those payments is a large challenge. So there are a number of methodological issues that make it challenging to do such an analysis.
I think that's...
I'm Alan Jensen with George Washington University and the Medicaid Infrastructure Grant Project Director here in D.C. Back in 2008, I did a study for Indiana University on their Medicaid buy-in program. One thing that we found was that 1/3 of those on the Medicaid buy-in are not have never received SSDI, or not receiving SSDI, and 44% of those at the end of that fiscal 2007, which is July of 2007, 44% of those physical disabilities were not an SSDI. Now, the context of that is that Indiana has 200 Benefits Information Network people, and they've trained all their vocational rehabilitation counselors in the work incentives, including Medicaid buy-in. So I think that now it goes much lower when you get to mentally ill and those with developmentally disabled, but we had a data set that could separate out that information. And so I think that looking at the Medicaid buy-in in combination with work incentives, people having an informed choice to be able to make, that they know that this program is available, I think is the other part of it. You call it the case management. What they did was to say that we're going to have a voc rehab-funded benefits information network. And then we also did a survey of those who were the benefits information network and the rehab counselors. And it clearly showed up that a very high percentage of them talked to their clients about the Medicaid buy-in as an option. So I think there's information to be gained from the Medicaid buy-in that I think Mathematics has done some of that work, but I was able to pull out more detailed information because of the nature of the data that Indiana had. So I think there's even more data to be mined out of that, which I think would be helpful.
Dale Brown, EconSys. I wanted to ask if you were planning any preliminary analysis of the people who did not apply but were still employed. I'm curious if there are any differences in accommodation from employers, maybe if there are other benefits they applied for, but just if you had done any thinking of that particular group of people, those who were still employed but did not apply.
You mean apply? Do you mean apply to SSA?
Yeah. You said that there was no impact on employment, but there was an impact on the numbers of people who applied to SSA. So my question is that little group that you think is a difference, have you done any analysis of the different, what they are like?
Well, the analysis, most people, of course, were still working and didn't apply. You're asking really what are the characteristics of those who did apply?
Yeah. I mean, for example,
Yeah.
did they receive more or less accommodation from their employer? I mean,
Right. Those are good questions.
Is there a difference in their earnings?
Yeah.
Is there anything you can see that would cause that?
Right. We haven't really started those analyses. We were just really looking to see, first of all, if there are differences between treatment and control group. But it's a great question, and we intend to do that in our next set of analysis this year.
Winthrop Cashdollar, America's Health Insurance Plans. Pat made a point about the difficulty of the heterogeneity of this population. I wonder in subsequent work if it might be feasible to identify populations not by state or not by state program, but populations where the common link would be a particularly significant disabling condition or illness that leads to a disabling condition, and that you could maybe choose conditions or illnesses that are having a significant impact now on, say, SSDI, and have a series, an array of parallel interventions, perhaps a significant intervention for a particular disease or a variation, so you could then maybe crystallize and have some more homogeneity or a series of homogeneous analyses.
Well, that's an interesting question. And so I want to make 2 points. One of them is that you couldn't just do it by diagnosis, because the diagnosis doesn't tell you much about somebody's functional capacity. You'd have to add some other additional information about functioning in the context of the workplace. But certainly it's possible to start at a diagnostic jumping off point. In a way, that's exactly what Hawaii did. Hawaii was focusing on one condition. And we learned a lot, or Hawaii learned, we all learned a lot about kind of the challenges in doing that. And, reaching people who are working, who are not in a public safety net program. So you have to go through the business community or do marketing, broad public marketing. That's tough to do. And you may get a very limited range of people who, with a particular condition, want to enter this kind of a program. Interesting question, raises a lot of other questions too.
And I think too, Winthrop, that that yes, the impairment is one slice of it, but these individual characteristics and the environment and all of those things introduce even into that particular slice, or that's not a good word, but that particular category, a lot of different questions of heterogeneity also. But of course, that is one way to do it. Think about it.
Matt Boris, Administration for Children and Families. I wanted to build a little bit off of some of what Ms. Brown mentioned in terms of accommodations as a factor. And in the presentation where you kind of showed, in the GAO presentation where you kind of showed some of the progression from the medical model to bringing in some of the environmental factors, in either some of the later analysis that you're planning on DMIE or in some of what GAO discussed in your experts meeting recently, was there any talk about really trying to look at and quantify some of those environmental factors, such as workplace accommodation, such as the availability of adaptive technology, such as transportation infrastructure, some of these things that really are a big part, and as the models have really been moving away from this hyper-individualized medical aspect, it seems like in a lot of our studies we really don't look at those as much as we should, partly because they're more difficult, but I wondered if there were thoughts on moving toward trying to identify some of that.
I can just say yes from our perspective. There is thought to do that, and that's what came out of the particular from the session on Tuesday, was that yes, we have to pay more attention to all these individual pieces.
And I would concur that workplace accommodations and what's happening inside the employer is very much an important factor in what's happening. In the DMIE, however, that information is not collected as part of the standard surveys. So we do have information on the industry in which the participant is employed and job type, but we don't know if there are workplace accommodations occurring and to what extent they're present.
Good question.
Hello, I'm Deborah Titus. I'm from Fairfax County. You said that this is preliminary findings from the national evaluation. My question is, Dr. Dunham or Dr. Erase, I don't know, we'll talk about lessons learned from about implementation on paid forces. I wonder, why not get the direct data from other entities such as treatment advocacy that is located in Arlington that always talk about treatment push for people with a mental condition. I want to know if you can collect data from them to see if they have worked with a client other than treatment push to see if they find any support system. Have you ever thought about that?
I understood your question. You're asking whether we have thought about collecting data from some other of the agencies who work directly with folks who have various kinds of disabilities, including mental disabilities. And the answer is we've thought about it. But we haven't, at least in the context of the DMIE, really were not able to, kind of pull it off. In many ways, I think we're identifying opportunities here of gathering really important data, not only from employers, but from existing programs that are already kind of in the field working. And, I think that's really important. And if we were to do this again, I think we'd try to figure out a way of doing that. So thank you for that suggestion, actually.
Hi, I'm Carol Boyer, and I work for the Department of Labor's Office of Disability Employment Policy. And we've had wonderful conversations with some of the GAO folks about the survey of stay-at-work and return-to-work intervention issues, which is very important. And all of my various colleagues have brought up a lot of the questions I had about assistive technology and all of that. But at ODEP, as many of you know in this room, we had 6 years of demonstration projects on customized employment, which is working with the employer and the individual. And it's similar to person-centered type of case management, wraparound services, all of these types of things. We entered in from the recruitment stage, but we see this now based on the data that we have, that people actually did get off of federal benefits, TANF, SSI, SSDI, huge numbers of an end population of more than 5,000 over the period, and it was more than 25 demonstration projects in the workforce systems, one-stop career centers within that. And we see that as a very good intervention in the retention stage as well. And it's very similar with what this particular project was doing, and some of our projects even did use Medicaid infrastructure grant money to proceed. So, and we have good sustainability going on, one of which is in Montgomery County, where Montgomery County is funding 2 years part-time customized employment internship project, which won a National Association of Counties award last year for a very innovative project. It's sustainable. We're not funding that, but we gave them the idea to do it, and it's running on its own, and Montgomery County, Maryland wants to keep that going. And we actually got into the Harvard Innovations Award Program. We made the top 20% last year. We're going to go for more this year. But it is something that we're presenting to GAO, and they have a lot of the data on this, and we're very pleased that some of the folks are here that are open to learning more about that program.
And thank you for all the materials. Thank you for the personal mail that I got in the package that was about that fix. Thank you very much.
You asked for hard copies.
I did. Thank you very much. I appreciate it.
Yes, thank you. John Tambernino, Social Security Administration. For Minnesota and Texas, you've got a population that's low education, low income, marginally employed. It'd be useful to have information on their participation in other forms of public assistance, unemployment insurance, food stamps, TANF, for a variety of reasons, in part because some of those programs are going to be encouraging them to apply for federal disability benefits, partly for some of these cost issues of shifting costs from the state to federal budgets. And to that extent, they could be getting these kind of conflicting messages and conflicting encouragement from participating in those programs and kind of being in that social services network as opposed to these medical health insurance-based interventions. Ideally, you'd have information, survey data from the participants on their knowledge and their motivations and just what their motivations are in terms of applying for disability or other forms of public assistance and what their knowledge of it is and just kind of how they see their options, given that they're working intermittently and have a disability.
Just 2 comments. One is that in terms of the motivation for applying for disability benefits, that is not part of the survey questionnaire that is part of the national evaluation. A number of states, though, have, as part of the interview process, are trying to get at that question of what prompted the intent to apply for Social Security disability benefits. And in some of the state evaluation reports that will be coming, there may be some information to shed some light on that. The second comment is with regard to other participation in other public programs. We did collect, as part of the survey, participation in TANF, Section 8 housing, some other public programs prior to enrollment to give some context of these populations. And as you would suspect, in Minnesota, we do see there's some prior participation in these public programs. So it's part of what we're collecting, not on an ongoing basis, but in terms of historical exposure to public programs.
In the back.
Actually, we're going to take a couple questions from the remote audience.
The first question is, what exactly were the early intervention services provided to the participants, and can you give some case examples?
The intervention services really varied state by state. I think some of the, as we mentioned in the early slide, in some of the slides, the intensive person-centered case management was an element that connected people and reduced barriers to accessing these services. With regard to medical services, these wraparound benefits included things like enhanced dental coverage that went above and beyond what was existing or standard coverage. Things like medical transportation, which was not part of the standard package of benefits. With regard to employment supports, Minnesota, just to give an example, had an 8-week peer support program where participants were given the opportunity to meet together during an 8-week period to talk about employment goals and identifying strategies to stay employed. So those are two very specific examples, but the details of the intervention services did vary by state, although the general idea and components were similar across the states.
You have another one at a time?
Sure. Okay. There was a recent article in the British Medical Journal that described the findings of the quantitative value in the days away from work. The two groups were an integrated systems approach to healing as well compared to a usual care. And the average difference between the two groups in days away from work was found in the study to be about 120 days or 4 months.
More detailed comment than we usually get. That's good. Let's save that one. I think we have another hand up.
My name is Jack McGarry from Unum. It seems that the study is really a study of the effectiveness of early intervention on people who have expressed an interest in staying at work. And have you given any thought to the applicability to the general population, because these were volunteers, I assume, as opposed to a total population in this situation?
Yeah, that is a really interesting question, because you're right. These are people who want to stay, who have a disabling condition, who want to work and want to stay working. And, you know, as far as I can tell, there really isn't any hard information out there of all of the people who happen to have a disabling condition. How many really want to go to work and stay working? In fact, if you ask people without a disability, would you want to go to work and stay working? You may get some unclear answers, or you wouldn't know how to interpret that information. So, I mean, we don't know what quite to do. You're not going to compel people to participate in a program like this. But it doesn't matter. We know that 15% of all people with disabilities, even defined in a fairly narrow way, are working full time. So there's a lot of people out there who are working, who want to work, and and maybe there is some information that I'm just not aware of who could answer that. But I think in any case, we can do this for the people who would volunteer. I mean, there are plenty of people who would sign up for something like this.
The BLS, I always have to ask David to help me out with these numbers, but the BLS now new statistic on unemployment for persons with disabilities and the employment rate, that says that there are a good number of people with disabilities out there looking for work. Is that true? Can you do the numbers for me? But it is, I mean, the people who are seeking work and out of work with disabilities is what, 2 times as high, 3 times as high as persons without disabilities. So if you just used that data, you would say there are a lot of people out there who want to work that aren't working, and that if somehow we could get that population into one of these systems, that would be what we want to do.
I'm sorry Gina Livermore didn't come to the room today because she, well, she did? She was there? Oh, okay. And we have a report out. In fact, I think the issue brief about it out here that looks at disability beneficiaries, SSDI and SSI recipients. And we've done a survey of beneficiaries and found out how many are working, how many are actively trying to work, taking various steps, and how many just say they expect to work over the next few years. And then we follow them for a few years to see what they actually do. And it's actually a fairly large percentage. So these are people who have already gone past early intervention, and many of a large number do want to get back to work. I think we have to wrap it up now. It's time.
I want to make a really quick
Okay.
related announcement. Hi, Claire Trivedi from HUD. Speaking of looking for work, there's a federal hiring event for people with disabilities, April 26th at the Convention Center. I left some flyers out there on your table. So if people want more information, there's also a web link on USA Jobs.
It's on the OPM job site, and you have to get the ODEP is doing that with OPM. Want to take credit for that? Thank you.
Yeah, good job, ODEP. Woo-hoo.
And people with disabilities have to get their resume into the site on or before March 24th. That's the deadline. And they actually are going to be hiring people on the spot because their resumes will be preliminary. It's a hiring expo. We're really excited. And ODEP and OPM jointly led with Department of Defense CAP program, the largest federal training on Schedule A ever. We had to turn people away. There were about 600 federal hiring managers there. So it's policy changing. It's not just a hiring expo. It's training to help change the policies within the federal government because we need to be a model employer.
Before we
Can I just, can I just make one final comment, which is Mathematica staff are delighted to stand up here and talk about the evaluation, but really the state folks, the program and evaluation staff deserve a lot of credit. They've also done a lot of publications of their findings and their process and their programs. So if you contact me or Gil or any of the Mathematica staff working on this, we can give you leads to additional information developed by the states. Also, thank you all for coming and for everybody who's on the phone.
I want to make one more announcement, and that is for our next forum, which is on May 19th. Deborah, is that right?
Yeah, we have flyers on it.
Yeah, there are flyers outside, and we're going to present several findings from several studies related to Ticket to Work, but they're actually focused on looking at the dynamics of employment behavior by Social Security beneficiaries. So we got some very interesting new statistics. If you think the answer to the question, what percentage of beneficiaries leave the rolls by going back to work is 0.5%, you've got to come to this session. Hope to see you there.